Welcome back, everyone. Today we're diving into heavy hitters of heavy muscle disease, the cardiomyopathy. I'm Dr. Fernandez, and we're going beyond the basic of echo to understand why these hearts fail, how they're wired, and the genetic hiding in the plain sight. Defining cardiomyopathy. So, what is cardiomyopathy? Historically, we call them idiopathic, which was basically medical speaking for we have no clue. Today, we define it as a disorder where the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, or valve disease that will be enough to cause the damage. The definition has evolved from just heart muscle disease to a broad spectrum of myocardial performance issues. We are looking at mechanical failure, like a pump problem, or electrical failure, leading to a life-threatening arrhythmias. The spectrum of the disease, think of it as a slide scale. On one end, you have primary cardiomyopathies, like hypertrophic cardiomyopathy, purely DNA driven. In the middle, we have mixed types like dilated cardiomyopathy. On the far right are the acquired invaders, a stress-induced like Takotsubo, inflammatory processes or toxins like chemotherapy. Dilated cardiomyopathy, an overview. Let's start with dilated cardiomyopathy. This is the classic big baggy heart. It is characterized by ventricular dilatation and impaired systolic function. It simply can't squeeze effectively. The impact of dilated cardiomyopathy. This isn't a rare niche issue. Dilated cardiomyopathy is the most common cause of heart failure and is the leading reason young people end up on the heart transplant list worldwide. The numbers are striking. It hits roughly 1 in 2,500 people. Even more significant is that up to 50% of these cases have a genetic basis, meaning it is often written into the family tree. Dilated cardiomyopathy etiologies, the Irish heart. What causes the heart to stretch out like this? Alcohol is a major player, sometimes called Irish heart in other texts. Heavy chronic consumption is directly toxic to the myocytes. Dilated cardiomyopathy etiologies, toxins and pregnancy. It is not just alcohol. Cocaine, chemotherapy agents like adriamycin, and even pregnancy, known as peripartum cardiomyopathy, can trigger these massive dilatations. We also have look for infectious triggers. Viral myocarditis is a common culprit where the body's immune response to a virus ends up damaging the heart muscle long term. Screening the family. When you find patients with dilated cardiomyopathy, you have to look at the family because of the high genetic link. Approximately 25% of the first degree relative will show some level of cardiac abnormalities when screened. On echo, we are looking for the increased left ventricular end diastolic dimension, LVEDD. The heart isn't just weak, it is physically too large for the patient's body size. Here's a pro tip for your echo. Look at the EPSS, the E point to septal separation. If the gap between the mitral valve and the septum is over 7 millimeters, you are likely looking at ejection fraction EF of under 30%. Hypertrophic cardiomyopathy. Let's talk about the thick heart. Hypertrophic cardiomyopathy is a totally different beast. It is defined by a thickened, non-dilated left ventricle in the absence of a cardiac or systemic loads. The dangers of hypertrophic cardiomyopathy. This is the most common cause of sudden cardiac death in young athletes. It affects 1 in 500 people in the general population, and many remain asymptomatic until a lethal event occurs. Hypertrophic cardiomyopathy is almost always a disease of sarcomere, the heart mechanical engine. It is inherited as an autosomal dominant trait, meaning if a parent has it, there is a 50% chance each child will also get it as well. Myocardial disarray. Under the microscope, Hypertrophic cardiomyopathy looks like chaos. We call it myocyte disarray. The cells aren't lined up in neat rows, they are tangled, which creates a perfect substrate for the electrical short circuit that leads to sudden death. Hypertrophic cardiomyopathy isn't a one-size-fits-all. The most common form, or about 75% of cases, are asymmetric septal hypertrophy, where the wall between the chamber is significantly thicker than the rest. Other shapes, but we also see other shapes, concentric hypertrophy, where the whole heart thickens, apical, which affects the tip, and even mid-ventricular or lateral wall versions. To diagnose hypertrophic cardiomyopathy on echo, we are looking for a wall thickness of 50 millimeters or more. If the patient has hypertension, we look for a more extreme ratio of 1.5 to 1 compared to posterior wall to be sure it's truly hypertrophic cardiomyopathy. The phenotype versus genotype. The shape of the heart can actually tell us about the genes. Different morphologies, like reverse curvature, carry different statistical weights for findings of positive genetic mutations. Reverse curvature septum. A reverse curvature septum, where the septum bows into the LV, is a massive red flag. It is 79 predictor of the patients being genotype positive for sarcomere mutation. A sigmoid septum is often seen in older patients, usually carries a much lower genetic link, only about 7%, and is often just a byproduct of aging and long-term blood pressure. A neutral septum then is essentially a vertical line. These patients fall somewhere in the middle with about 40% chance of being genotype positive. The pathophysiology triad. Why do these patients feel so bad? It's a perfect storm of three things: ischemia, lack of oxygen, diastolic stiffness, the heart can relax, and outflow obstruction. About 70% of hypertrophic cardiomyopathy patients have what we call obstructive physiology, either at rest or during exercise. This is what causes the fainting and the classic harsh murmur. Systolic anterior motion. This obstruction is caused by systolic anterior motion of the mitral valve. The Venturi effect literally sucks the mitral valve leaflet into the outflow tract, blocking the blood path to the rest of the body. Spectral Doppler, the dagger. On your spectral Doppler, this looks like a dagger-shaped jet because the obstruction happens later in the squeeze. The velocity peaks late, creating the sharp pointed appearance. Distinguishing the jet, you have to be careful. Don't confuse the LVOT jet with mitral regurgitation. They look similar, but they tell very different story. The LVOT profile, the LVOT jet is late peaking and looks like a dagger. It represents the actual blockage preventing blood from leaving the heart. The mitral regurgitation, on the other hand, is usually holosystolic and has a more rounded U shape. Getting this mixed up can lead to completely wrong diagnosis. The diastolic dysfunction. Even without a blockage, these hearts are stiff. They can't feel properly because the muscle is so thick and scarred, leading to high pressures in the lungs and shortness of breath. The L wave. Look for the L wave on your mitral inflow Doppler. This extra wave between the E and the A indicates severely delayed relaxation and very high filling pressures. How do we treat this? Beta blockers are our first line defense. They slow the heart, allowing more time for stiff muscle to fill and reduce the sucking effect of the systolic anterior mitral. Alcohol septoablation. If meds fails, we can try alcohol septoablation. We essentially cause a small controlled heart attack by injecting alcohol into the artery feeding the thickened septum, causing it to shrink. This is an interventional procedure. Patients also can go surgical myectomy. Then there's the gold standard, the Moro procedure or surgical myectomy. A surgeon literally carves out the obstructive muscle to clear the path for blood flow. The results of successful myectomy are incredible. It is not only reliable symptoms, but can return the patient life expectancy to nearly that of the general population. Newer medications are also on the market right now. Risk stratification for sudden death. The biggest questions we face is how we get an ICD. We use specific risk markers to decide who is at higher risk of sudden cardiac death. Apical hypertrophic cardiomyopathy. Let's look at a unique variation of apical hypertrophic cardiomyopathy. This is much more common in Asian population. It can be easily missed if you are looking at the very tip of the heart, the ace of spades on the ventricular or with the echo contrast. Apical HCM gives the LV ace of spades appearance. The cavity is virtually obliterated at the bottom. EKG findings on the apical hypertrophic cardiomyopathy. On the EKG, these patients will have massive, deep, giant T wave inversion. If you see those on routine EKG, you must look at the apex of the heart on the echo. Hypertrophic cardiomyopathy mimics other syndromes, including Noonan's syndrome. Not all thick hearts are hypertrophic cardiomyopathy. Noonan's syndrome often presents with a thickened heart, but you also usually see pulmonary valve stenosis, which is a huge clue. Friedreich's ataxia is a neurodegenerative disease, but the heart changes can actually show up decades before the neurological symptom. These patients often develop a concentric form of hypertrophy. Fabry's disease is a storage disorder. The heart isn't thickened because of the muscle growth, but because it's being stuffed with metabolic waste products. This requires a completely different approach for the treatment. Athlete's heart dilemma. Finally, the ultimate clinical challenge is an athlete heart or ACM. This is critical distinction for young persons, careers, and life. An athlete heart will be enlarged, but the cavity size also bigger, and the diastolic function, the relaxation remains perfectly normal or even superior. If the wall is between 13 to 15 millimeters, we're in the gray zone. If the cavity is small and the heart is stiff, is ACM. If the cavity is large and the heart is relaxes well, it's likely just a result of training. Strain can also help to distinguish this. Cardiomyopathy is more than a diagnosis, it's a genetic roadmap. Use your echo, check the family history, and always watch for that